Hello, my name is Angela Smith, and I'll be presenting on lumbar degenerative disc disease. Degenerative disc disease is the most common cause of spinal pain in the world. It affects 40% of people ages 18 to 30, and if you include those under 50, it's 70%. 90% of people ages 60 and above are affected by degenerative disc disease. Despite the name, this is not a disease, and it's not necessarily progressively debilitating. It's historically been believed to be caused by aging, environmental factors, occupational influences, and social things such as smoking and mechanical trauma. But research has shown that these factors are actually secondary cumulative contributors, and the primary etiology is genetic. Some people possess genetic factors that predispose them to premature degeneration of their discs. A healthy spine is composed of vertebrae, 33 of them, that stack one on top of the other like puzzle pieces. They have a spinal canal that allows the passage of the spinal cord, protects it, and allows movement of your back and the rest of your body. There's three curves: the cervical curve at the neck, the thoracic at the upper back, and the lumbar in the lower back. You have supporting muscles in your abdomen, back, buttocks, and legs that help to support your spine and also facilitate movement. The facet joints and intervertebral discs between each of the vertebrae facilitate movement, and they also provide some space between each of the discs, keep them from rubbing together, and also prevent compression on the nerves and the nerve roots that exit at the foraminal spaces. There's a little canal that goes between each of the vertebrae that allows the branching nerves to go from the spinal cord out to the rest of the body. The intervertebral discs are gelatinous and hydrophilic. They are filled with fluid, and inside the disc there's pressure, so intradiscal pressure, that resists compression and deformation. Between the disc and the vertebrae, the end plate is an end plate cartilaginous layer, and nutrients and waste are diffused through this end plate to keep the discs healthy. The middle of the disc is composed of the nucleus pulposus. That's the gelatinous part. That's surrounded by the annulus fibrosus, which is tough and flexible, and it's made of concentric layers, the lamellae. The nucleus pulposus of the intervertebral disc is composed of the hydrophilic gelatinous extracellular matrix. It's rich in collagen. It binds water molecules to produce a high net swelling pressure to resist compression and deformation. The degenerative changes that occur in the nucleus pulposus occur with aging and injury, but genetic factors increase or cause these changes to happen prematurely. Some of the changes that happen cause the type 2 collagen to decrease and an increase in type 1, which is not as flexible within that nucleus. This yields a loss of functional aggregate and progressive loss of ability of the extracellular matrix to bind water. So eventually that nucleus becomes more fibrous, it resists diffusion of the nutrients, and it becomes dehydrated. This decreases the intradiscal pressures, and it's not as able to resist compression and shear forces. The degenerative changes of the nucleus pulposus are compounded by similar degenerative changes in the annulus fibrosus. The tough, fibrous, and flexible outer ring of the intervertebral disc surrounds the nucleus pulposus. It supports and contains the nucleus, and the degeneration is largely due to the delamination of the concentric laminar rings. Regeneration of this delamination yields fibers that are less flexible and more brittle. This weakens the support of the nucleus, which leads to bulging and herniation of discs. As you can see in the images below, the one on the left shows the laminar rings and how the disc sits between the vertebrae. The image on the right shows a normal disc, and the image on the right of that right image shows the compression on the nerve root when the annular fibrosis is compromised and the nucleus herniates. Most degenerative disc disease is asymptomatic. This is largely due to the fact that it is highly compensated. The mechanisms for compensation involve the supporting muscles of the abdomen, back, legs, and buttocks. The abdomen and back primarily help to support the spine and keep it in alignment. The muscles of the buttocks and the legs help support the load-bearing work of the spine. And good body mechanics is important to maintain the health of your spine by using those bigger muscles to help support the loads that your body bears. Another compensatory mechanism is seen in the image at the bottom there on the right. There's 3 phases to degeneration. You've got the textbook normal, it goes to some minor degeneration, then to some more major degeneration. You can see the breakdown of the vertebrae, or the decreased disc height, some of the osteophyte formation, that's the rigid looking stuff that's actually bone spurs that can compress on nerves. And then eventually it goes to phase 3, which is an autofusion. So the vertebrae above and below that disc end up with some osteophyte formation that ends up fusing the 2 vertebrae together. This is similar to the fusions that we do surgically in the neurosurgery clinic where I work. Our surgeons perform these surgical fusions, but your body actually does it themselves sometimes. As I said before, the presentation is usually asymptomatic, but when you do have symptoms with degenerative disc disease in the lumbar area, you get low back pain. This back pain can be from several different types of pain. The discogenic pain is a nociceptor stimulation from the annular tear. Inflammation also irritates spinal nerves. And ischemic pain can come from blocked vessels at the site of the compression. Due to the nerve compression and or nerve root compression, you also can get disruptions in the signals going from the brain to the spinal cord and to the periphery. So you get some numbness and weakness in the lower extremities. You can have numbness in the groin, genitals, and rectal area. Some people have discoordination and difficulty walking. Loss of bowel or bladder control is also one of the more emergent symptoms that we see. And oftentimes there's a difficulty in starting the stream of urine. And like I said before, a lot of this has to do with disruption of those signals going up and down the spinal cord. And so at the site of the compression, then you get those interruptions that cause the numbness, weakness, and discoordination. Diagnosis of degenerative disc disease is fairly complex. Due to insurance constraints, usually it goes through a primary care provider and conservative measures, and then it might go to a revisiting of the primary care provider, and eventually a referral to an orthopedic doctor or a neurosurgeon, and then you take forever to get into there, and then they get more imaging with the x-rays, and then they have to have an appointment to support advanced imaging and other tests. So a lot of the patients that we see when they finally get to neurosurgery have been dealing with their symptoms for many years, sometimes decades. The diagnosis is established with a health history and physical exam, neurological exam. They check reflexes, flexibility, gait, and pain distribution. Any of the other symptoms that were mentioned before. X-rays are reviewed on that first exam with the anterior, posterior, lateral flexion and extension views. They give a good look at the bones and the disc heights, and the flexion and extension shows the mobility of the spine in the different positions. That can show sometimes some instability when the disc moves anteriorly. If warranted by the x-rays and the physical exam, then further testing can be done with the MRI without contrast. A CT myelogram can show the signals going through the spinal cord. The EMG, or nerve conduction velocities, also showed nerve conduction, and the discogram, which is also another contrast study. For patients who present to primary care with symptomatic degenerative disc disease, their prognosis is quite good, actually. With symptoms, 2/3 of the patients recover with rest, anti-inflammatory medications, and 6 to 12 weeks of physical therapy. Strengthening of the back, abdominal, and large muscles in the buttocks and legs help to support the spine and can delay or prevent the need for surgery. Some other things that they can do is smoking cessation. Smoking greatly increases the risk of complications from degenerative disc disease and can advance the degeneration prematurely. Weight loss is also another thing that can help people recover from the symptoms of degenerative disc disease and acute exacerbation. With the more weight you carry, that's more load on your back, and weight loss can greatly help your back to not have so much work to do. Surgery is reserved for refractory cases with debilitating symptoms that are persistent for at least 6 weeks despite conservative measures. Oftentimes, patients have to, if they are smokers, they need to quit smoking and prove that they've quit smoking with a series of urine nicotine testing. In addition to making sure that they are a candidate for surgery in that respect with the social factors, they also may, depending on their comprehensive health profile, need clearance from their primary care provider for medical clearance for surgery, as well as if they have any specialists that follow them for cardiac issues, they'll need cardiac clearance for surgery, as well as the other specialties that may work with them. Research is in development right now for intradiscal biologic therapies to mediate the progression of degenerative cascade, and they're even exploring therapies that could induce repair and regeneration of the intervertebral disc complex. research has shown that the genetic factors are primary in influencing the development of degenerative disc disease. It's not entirely understood how this is how it affects it and what can be done about it. They're not exactly sure which of the players are most influential in how they are or how they can be manipulated. So that research is ongoing. The disc repair and regeneration with biologic strategies is a hotly sought after research, and they are working on those therapies very aggressively. The protein and growth factor injections that they're working on are to prevent degenerative changes from occurring. Also, gene therapy is with the intent to prevent degenerative predisposition for those that have those genetic factors. The cell therapies that they're working on are to repair and induce regeneration for damaged discs. And this, they're working with some different types of cells, and those include chondrocytes, disc cells, embryonic stem cells, hematopoietic stem cells, and mesenchymal stem cells. The clinical trials have indicated that the mesenchymal stem cells are the best choice for intervertebral disc regeneration. Here are the references for my presentation. If you have any questions, I welcome you to post them to the discussion board, and I'm happy to answer.